thing. So I'm recording it. Is that fine with you?
Yeah,
All
that's fine.
right, perfect. Okay, so we're just gonna start this interview off by if you can just provide a brief explanation of just like what you do and what you were a part of.
All right. Well, I'm Chirag Patil. I'm a neurosurgeon at Cedars-Sinai Medical Center, and I specialize in treatment of brain tumors.
And just thank you for your time again. I mean, the first question I'll start with, it's going to be kind of introductory level. So we know that cancer, you've done work specifically with cancer and those type of brain tumors, and we know that it's basically uncontrolled cell division, and that's what cancer is. But I think when a lot of people are introduced with neurology and when they're introduced with those type of brain tumors, it's kind of a disconnect, mainly because neuron cells specifically can't undergo or can't undergo, mitosis or even cell division. And we hear the term brain tumor being thrown around constantly, but if neuron cells can't undergo mitosis or divide, how exactly do brain tumors start in the first place?
Yeah, that's a great question. Well, actually, in the last 20 years, really, we've actually shown that neurons can divide. So used to be thought that neurons cannot divide, but that's not true. There's actually stem cells and other primitive neurons that can divide. Not all neurons do, but they are able to regenerate themselves. And that's one of the ways that people with stroke will recover over time. Part of it may be neuroplasticity, but also part of it is that neurons do actually divide and undergo mitosis. So there's been research that's kind of debunked the old theory that they cannot divide. But having said that, most of the tumors actually don't come from neurons in the brain. So they come from glial cells, which are the support cells of the neurons. And there's actually 2-to-1 or 3-to-1 ratio of neurons to glial cells, depending on the location of where you are in the brain. And so the most common primary brain tumor, meaning that the tumor that starts in the brain itself, that's malignant, actually starts from glial cells, which are these support cells that do divide quite a bit, a lot more than neurons. So they're kind of more like normal cells. And so they form gliomas. So the most sort of the most aggressive one's called glioblastoma. And again, glio means glial. So they're not neuronal, but they're glial. And those have quite a poor prognosis. There are some glioneuronal tumors as well, where their neural tissue is part of the tumor, but it's very rare to have purely a neuronal tumor because neurons, as you said, they do divide, but they divide very slowly if they do. So it's hard to form tumors from them. The other portions, where people call brain tumors, can be from other elements. So one element in the brain or the head is glia, so it's gliomas. They're meninges, which is a covering of the brain, so you can have meningiomas. There's Schwann cells that cover the nerves, and that can lead to schwannomas. And so most tumors in the brain don't start from neurons.
Mhm. And I specifically saw through thank you for that answer. I specifically saw through your research also that you worked with metastatic brain tumors, tumors that start or cancer that starts in different parts of the body and then transfer over to the brain. Specifically, not just regarding to metastatic brain tumors, but brain tumors in general. How have strategies towards treating brain tumors changed over time? Specifically, when you first started practicing neurology compared to now? And then second, will there be any changes driven by technological advancements in the future, specifically by AI or something else?
Yeah, absolutely. Things are changing, I think every few years in rapid succession in neurosurgery and in the rest of really the medical field. So, for example, a couple of the new technologies that we didn't have even a few years ago One would be, say, laser ablation. So instead of removing the tumor, doing a large craniotomy. So here's my little skull model, and for a craniotomy, you would need like a large area that you remove and then take out the tumor. Some of the tumors we can just simply put like a little burr hole like this and insert a laser um, directly into the tumor, and with laser heat, precisely control where the ablation is going to be. And that ablation actually takes place in the MRI machine. So some of our treatments are now taking place not in the operating room or partially in the operating room, but the treatment actually is taking place in the MRI machine, because then we have real-time feedback on what tissue we're heating up to kill, make sure that we're only killing the tumor and the heat is not dissipating too much to the surrounding brain. So laser ablation of brain tumors would be a great example of that. Other examples are sort of more minimally invasive surgery. So again, instead of like a big craniotomy, we're using this like small tubular system, which is the size, of there's smaller tubes even, but this is the size of a dime. And essentially we insert this into the brain, and then, operate essentially the whole operation through this little tube, instead of, doing a large traditional craniotomy. The third last thing I would say is a focus ultrasound. We are actually able to heat tissue deep in the brain. So I just did this treatment last week where we had a patient. We had essential tremor, a bad form of tremor, action tremor, and we were able to simply put a helmet on the patient that has all these beams of ultrasound energy that converge onto one small little spot about a millimeter by millimeter. And we're able to direct all those beams to that exact spot of the thalamus that is involved with abnormal tremor. So we can ablate that, and the patients will have immediate relief in like 30 seconds. It's actually pretty dramatic. I have some pictures that I can show you later of that.
All right, great, great answer. I think for the next question, I would like to shift my focus just like for one question I had specifically, just like a personal question. And I'm sure you've heard of the claim of malignant brain tumors, specifically being a metabolic disorder or disorder that's like driven by glycolysis. Like that's a claim. It's driven by the dysregulation of glycolysis and respiration. I just wanted to hear your opinions on that, new medical claim, and whether a keto diet would actually work in solving a lot of cancers.
That's a great question. Tej, actually, we just opened a NIH-funded large trial of ketogenic diet for glioblastoma and malignant brain tumors at Cedars. So Dr. Jethro, who HU is leading that effort, and so we don't think that's the full answer, because again, cancers come, like you said, from uncontrolled cell division and mutations. But once they have those mutations, they do use these abnormal metabolic pathways where they don't go through the TCA cycle. They only use glycolysis, and then there's so it's very inefficient, but it can do it can basically produce a lot of sugars very fast, so that it doesn't have to go through the whole Krebs or TCA cycle. That also produces some substances that actually depress the immune system and help the tumor basically evade detection and basically grow faster. So I'm a PI of another clinical trial that's sponsored by Berg, and metabolic treatments are kind of the next sort of hot thing in cancer therapy in general. So this clinical trial has coenzyme Q, which is sort of placed in a nanopolymer, so we can deliver very high doses of it, and essentially it forces the tumor to actually go into the Krebs cycle, the TCA cycle. And so by doing that, they hypothesized that a lot of the advantages that these malignant tumors have by sort of hijacking and making this metabolic sort of pathway very abnormal, by normalizing the pathway, that actually will lead to apoptosis, decreasing the growth rate, and things like that. So I think it's definitely the new frontier.
Mhm. Great. And then just this is the last question. I just wanted to quickly shift our discussion to how our immune system responds to glioma, which is basically a growth of cells that start in the brain or spinal cord, for people who are watching. Um, is there any type of new technology or current technology that you plan to use or are currently using that basically inhibit and regulate the expression of that FASL protein that causes immune cells to die?
Well, I think the immune system, is critical in fighting off cancers in your own body that are created probably, not that infrequently. We don't have great data on how frequently they're created, but most of the time, the different mechanisms, apoptosis or immune cells basically find those abnormal cells and they kill them. And so, harnessing the immune system to kill a tumor that's already is there now, I think has been a great strategy for many tumors like melanoma. And, has changed the prognosis dramatically in several tumors. So that's really been in the last, I would say, 5 to 10 years, the biggest win as far as therapeutics for cancer has been immunotherapy. So there's lots and lots of different targets that we're looking at. I have a clinical trial looking at anti-PD-1, which is a medication like Keytruda that basically enhances the immune response of the body and doesn't let essentially the tumor block the immune response. So the immune cells are very good at basically producing cytokines and also having receptors that bind to the tumor cells and they bind to the immune cells and turn them off. So essentially, we're trying to figure out how to turn those immune cells back on. And there's lots of different strategies, not just one, single sort of target. Immune system is very complex with, lots of different molecules that are controlling it. And so different people are looking at macrophage modulation, T cell modulation, killer T cells, NK cells. So lots of progress there. But in GBM and gliomas, it really hasn't worked so far. So we're trying, but hasn't really worked so far like it has for melanoma and many other cancers.
All right. Thank you. That's the end of the interview. Thank you so much for your time.